Hello. Hello, everyone. Good afternoon and welcome to one of the industry-sponsored symposia. So we've all been talking about COVID, but there are other illnesses that we have to consider. We would like to thank Roche for this symposia, who will tackle and the speaker will now tackle issues and new approaches in fighting another deadly virus, which is influenza. Thank you very much, and I hope you learn a lot from this session.
Thank you so much, Dr. Gelzame Zabat, for that very warm welcome. And good afternoon to you guys, dear doctors. My name is Susie Entrata Abrera, your moderator for today on the industry-sponsored lecture from Roche, One and Done, reducing the burden of adult influenza through a new antiviral treatment with a novel mechanism of action. I'm here to introduce our speaker this afternoon and also to facilitate our open forum after the talk. Now, this afternoon's speaker is an internist who specializes in the diagnosis and treatment of infectious diseases and a fellow of the Philippine Society for Microbiology and Infectious Diseases, as well as the Philippine College of Physicians. He studied at the University of the Philippines, earning his bachelor's degree in biology major in microbiology in 2000, and then his doctor of medicine degree in 2005. He is an infectious disease specialist in a number of leading hospitals in South Luzon, including the Medical City Santa Rosa, QualiMed Hospital Santa Rosa, and Calamba Medical Center. Ladies and gentlemen, I give the floor to Dr. Mark Christopher Pasayat.
Good afternoon, everyone. Thank you, Susie, for that kind introduction, and thank you for moderating my talk this afternoon. I hope I'm coming to you very clearly, and let me just first share my slide. Okay, my slide's okay, right? All right. So again, good afternoon, everyone, and welcome to this industry-sponsored symposium, the last day of the PISMED annual convention, and we're here to talk about influenza and a novel antiviral treatment for influenza. I'd like to inform everyone that this is an industry-sponsored talk by Roche Philippines. And as a disclaimer, I'd like to first state that in this session, there will be updates on ongoing or just completed phase 1 to phase 3 trials of new drugs and new indications from any of the pharmaceutical companies. And for some drugs and indications, the Philippine FDA has yet to review and approve such in terms of efficacy and safety. As for local and global regulations, physicians are cautioned against off-label prescriptions until the Philippine FDA has given its approval for the use of such unregistered drug in such new indication in the Philippines. And this information should not be construed as a recommendation for use of any product for unapproved uses. So this talk aims to, number one, describe the burden of influenza globally and locally. Also, we will review the present management of influenza based on the current clinical guidelines, who should be tested for influenza, what kind of patients should be treated for antivirals against influenza, which antiviral should be prescribed at what dose and for what duration, are the current guideline recommendations, and when should bacterial co-infection be considered or investigated or even treated when we're dealing with an influenza infection. And lastly, I'd like to introduce Baloxavir marboxil, which is a new antiviral treatment for influenza just recently approved by the Philippine FDA. So in 2018, in 2018, we actually commemorated the 100th year anniversary of the Spanish flu. And this is one big pandemic in the last century, which infected 1/5 of the world's population and claimed the lives of nearly 50 million people. In PISMED 2018, I actually gave this talk. The viral fluctuations, I talked about new avian influenza H5N1 and H5N6. And I mentioned there that on that year, we were actually commemorating that Spanish flu pandemic of 1918. And I remember saying that we might have a pandemic anytime soon, whether it's a new viral infection or it's influenza, we don't know. And look what we have now. Now, 2020, we are actually experiencing a global pandemic, not with influenza, but with coronavirus. So what is influenza? It's a highly contagious viral infection involving the respiratory tract. Once you are exposed to this virus, there's 1 to 4 days of incubation period wherein you will not feel anything, you will not experience anything until um, you start to develop symptoms. And you are uh, contagious at least a day prior to the onset of symptoms. And when you have all these symptoms, fever and respiratory symptoms, that's a time that you have a high viral load, that you are very contagious, and these symptoms and the infection will last for around 5 to 7 days. Remember that the CDC definition of influenza-like illness, or the ILI, is fever that's more than 37.8 degrees Celsius, and respiratory symptoms. And the respiratory symptoms are cough, nasal congestion, and sore throat. Now, on the left side in blue are the common symptoms associated with influenza. Symptoms may be local or systemic. And on the right side in orange are the complications. And remember that influenza infection might involve a lot of complications, not just the respiratory tract, but also neurologic down to cardiac and even musculoskeletal, and also pose a big risk among pregnant women. Now, the risk of developing secondary complications because of influenza is greatest among the high-risk patient groups. And who are these patient groups? Those with medical conditions and chronic illnesses such as hypertension, diabetes, or even obesity. That's a big risk factor. Extremes of age, children under 5 or people who are more than 65. Also, pregnant women is a high-risk patient group, even after 2 weeks after delivery. Those with reduced immunity, those who had asplenia, those with HIV, or even those who were on prolonged steroid use. And also residents of nursing homes and other long-term care facilities. These are considered high-risk patient groups, and if they have the influenza, we might see a lot of complications among these patients. Now, there are 3 types of influenza viruses, A, B, and C. And the most common among humans would be A and B. You only see influenza in animals. A and B would usually cause pandemics. They are vaccine preventable, but pandemics usually involve influenza A. But also influenza A would have animals as natural reservoir. Now, this is an illustration of the life cycle of influenza. Now, a lot of you probably have seen this kind of life cycle because of the coronavirus, and it actually has the same as that of the coronavirus. It involves viral entry because of the attachment of the virus to a certain receptor in human cell, which makes it capable of invading human cells. And then the uncoating of this virus, once it enters, it has penetrated the human cell, and the release of the core elements. And then the incorporation of this of the viral genetic materials with the human genetic materials, and thereby causing multiple replication and multiple copies of the viral genetic material. And the assembly of new viruses because of the certain proteins. This virus can now produce other viral or small viral particles until it's ready for release by budding. and that's the release of several other viruses, thereby causing or infecting another set of human cells. Now, in the history of medicine, these are the notable pandemics where influenza is very much associated. In 1918, the Spanish flu involving H1N1. In 1957, the Asian flu involving H2N2. In 1968, involving H3N2, the Hong Kong flu. And the more recently, in 2009, the influenza A H1N1. Remember, all these viruses involved influenza A. I guess what's most of us have experienced is that H1N1 13 years ago or 12 years ago. Also, take note that Spanish flu killed around 50 to 100 million deaths. It involved 1/5 of the world's population, and the most recent one only involved 200,000 deaths. Now, comparing that to SARS-CoV with COVID-19, to date, we have 65 million cases globally and around 1.5 million deaths because of COVID-19. Okay, now I've been talking about seasonal and pandemic influenza. Not all influenza A can cause pandemics, but some influenza A can recur seasonally or annually and may cause a lot of infections in humans. And those are the seasonal influenza, usually H1N1 and H3N2. And there are pandemic influenza that usually occur rarely, at least 3 times in a century. Immunity is usually established with seasonal influenza, while there's no immunity or little immunity involved in pandemic influenza. Now, people who are otherwise healthy are at low risk for seasonal influenza, but those with other comorbids might be at high risk for complications because of seasonal influenza. Now, in pandemic influenza, otherwise healthy individuals may be also at high risk for serious complication, and not just those with other comorbids or the high-risk groups. Now, we have vaccines available for annual influenza seasons, while for pandemic influenza, there's no vaccines. Usually, there's no vaccines developed for these influenza strains. Now, antivirals for seasonal influenza, it's available and very much studied, while for pandemic influenza, usually antiviral supply are inadequate, or if it's available, it's for experimental use. Now, the rates of medical visits, complications, and hospitalizations may vary from low to high in seasonal influenza, while in pandemic influenza, it's moderate to high. Now, the impact of seasonal influenza, very limited impact in the general public, domestic and world economies, while it has major impact, or pandemic influenza has major impact to the general public. Now, viruses are very common causes of infections, but it's very rarely diagnosed, probably because, number one, diagnostics are not readily available, and if it's available, it's very costly. But studies have shown that among patients with severe acute respiratory infection, viruses remains the most common cause of such condition. So the most common viruses involved in pneumonia, involving or requiring mechanical ventilations, would be your rhinoviruses, enteroviruses, influenza A, and your RSV. However, it's very difficult to detect or even diagnose the presence of these viruses unless you have the diagnostic tool, or your institution has the diagnostic tool for this. Now, viral pneumonia related to respiratory failure results in severe critical illness and often associated with shock. Unfortunately, in a lot of clinical practice, when you have severe acute respiratory infections, you always think of bacteria, and you always start patients with empiric antibiotics. not realizing that this might not be bacteria. It just might be actually just a virus, and this will not require very broad spectrum antibacterial medications. Now, the crude mortality rate and resource use in the setting of viral pneumonia and acute respiratory failure are substantial and nearly indistinguishable from those related to bacterial infection. And that's what we usually experience in clinical practice. Okay, identifying such subjects presents an opportunity for discontinuing antibiotics. Correct, because if you think that this is a viral a pneumonia caused by viruses and not bacteria, then you may de-escalate your antibiotics or stop the antibiotics. In the recent IDSA guideline for community-acquired pneumonia, they recommended that if there is a high suspicion for viral cause of pneumonia or influenza, then you may start antiviral. But if it has been ruled out already and this is indeed bacterial pneumonia, then you might discontinue the antiviral medications. Now, this is a local study of the common pathogens isolated in patients presenting with severe acute respiratory infections. And this is from January to December of 2018. And out of the 1,378 SARI cases, 88 cases had positive results. And the most common etiologic agent causing SARI in the Philippines are actually viruses, from influenza down to enterovirus. Influenza, 29% had 29% of the cases is because of influenza A, and 8% is because of influenza B. And the rest are the other common viruses causing respiratory tract infection. So yes, viral infection exists and is a common cause of respiratory tract infections, whether globally or locally. So influenza is a virus that causes acute respiratory diseases. It is highly contagious, especially during the prodrome and during the symptomatic stages of the infection. It may result to serious secondary complications among the high-risk groups. It can infect, and it has the machinery to invade epithelial cells of the respiratory tract. And influenza viruses are continually evolving. And that's proven by a lot of pandemics. Influenza viruses that are naturally in animals as a reservoir, but it can invade humans because of genomic reassortment and mutation. And that's the capability of influenza. That's why it can cause a lot of infections in humans and can cause pandemics. So let's go to treatment. We'll talk about how to treat suspected and confirmed influenza, which antivirals should be prescribed, dosing, and the duration, and the role of antivirals. So caveats in antiviral treatment. The initiation of empiric antiviral treatment should not be delayed while influenza testing results are pending. Remember that antiviral treatment is clinically most beneficial when started as close to illness onset as possible, at least within the 48 hours from onset of symptoms. The CDC, Center for Disease Control and Prevention of the United States, just revised its recommendation for influenza management. And it is now recommending that for seasonal influenza, a range of antivirals are recommended for treatment of otherwise healthy patients, that's the OWH, including the new antiviral Baloxavir. So for oseltamivir, the classic anti-influenza medications that we have, it is still the treatment of choice for hospitalized patients, and to be initiated as soon as possible, even if more than 48 hours after symptom onset. Baloxavir, on the other hand, is not currently recommended for hospitalized patients due to lack of data, and the guidelines acknowledge awaited flagstone data. Now, the latest update also recommends that empirical influenza antiviral treatment be used in specific high-risk patient groups during periods of co-circulation of influenza and, remember, even SARS-CoV-2. And that makes everything even more complicated. No? Lalo na December, January, February, that's influenza season. And we still have the COVID-19 pandemic around the area. This is a very busy slide, but this just tells us the current recommendations for the use of antivirals for those patients with acute uncomplicated non-hospitalized influenza and the hospitalized severe influenza. And oseltamivir remains the drug of choice for both settings, and this should be initiated within 48 hours of illness or as soon as possible, even if treatment is started more than 48 hours after onset of illness. Now, the duration varies. The current Sanford recommendation is 5 days of treatment for influenza. And also, chemoprophylaxis may be given for those who were exposed to cases because of influenza, or for those patients at high risk of complications or severe immune deficiencies. Antiviral chemoprophylaxis is not recommended if more than 48 hours have elapsed since the first exposure to a person with influenza. Again, remember, these are chemoprophylaxis. These are post-exposure prophylaxis recommended for influenza and not for COVID-19 or SARS-CoV-2. And oseltamivir remains the drug of choice. I think oseltamivir or oral Baloxavir. Sorry, for the treatment, not for prophylaxis. Now for novel influenza A virus. When you say novel influenza A, these are the influenza A viruses that can cause pandemic, like the H5N6, the H1N1. So what do we do with them? Well, still oral and enteric administered oseltamivir is a drug of choice. It should be started as soon as possible within 48 hours from the onset of illness. The duration varies, whether 5 days or 10 days. And chemoprophylaxis is also available for novel influenza A virus. But it's very difficult with novel influenza because you need to tap epidemiologic data, whether there's really the need to give chemoprophylaxis, especially if this is novel or this is a new virus infecting humans. Now let's go to Baloxavir marboxil, or the Xofluza. We'll talk about the mechanism of action. We'll talk about the one-dose, one-time regimen. Remember, what I told you before, for oseltamivir, usually it's 5 days to 10 days, depending on the severity of the illness and the clinical guidelines recommendation. Sanford is recommending it as a 5-day regimen, twice-a-day regimen. And we'll talk about the one-dose, one-time regimen. And also, I had fun actually reviewing the CAPSTONE-1 and CAPSTONE-2 clinical trial results. This is Baloxavir. It's one of the new anti-influenza medications. This is just comparing Baloxavir with other anti-influenza. I think what's available in the country is oseltamivir. Don't mind the other two. I don't think it's available in the country. And it has Baloxavir has been approved by the US FDA for the treatment of influenza. And on August 2020, just this year, the Philippine FDA has also approved Baloxavir for the treatment of uncomplicated influenza in patients aged 12 years and older who had symptoms for less than 2 days. Baloxavir is the oral prodrug of Baloxavir. Marboxil is an oral prodrug of Baloxavir, and clinical trials have been made for Baloxavir, and we will discuss that in the subsequent slides. Just a quick review. There are different antiviral medications, and they act on different mechanisms of the viral replication. For example, the amantanes They act on the M2 ion channel inhibitor, and rimantadine is one of the adamantanes that people use in clinical practice. Now, the neuraminidase inhibitors are your oseltamivir. So it actually affects the release of the new virions from the epithelial cells. Now, going to the new drug, Baloxavir, it is a polymerase inhibitor. So it affects the replication of the virus within the epithelial cells by inhibiting the 3 different polymerases in the life cycle of the virus. And this is the action of Baloxavir. It inhibits your endonuclease activity. Compare that with oseltamivir, which affects your neuraminidase, and compare that with the more commonly used drug nowadays because of the pandemic, the favipiravir, which inhibits your mRNA elongation. Please take note also that favipiravir is an anti-influenza medication that is approved in Japan. That's the initial usage of favipiravir. And this is a summary of the different polymerase inhibitors. Take note that Baloxavir affects 4 polymerases, while Pimodivir and favipiravir only affects the less number of polymerases. Okay. Again, Baloxavir, marboxil, sorry. Okay. The mechanism of action is that it inhibits your polymerases, thereby inhibiting viral replication. The usual dosage is 1 day, single dose. It comes in 2 formulations, 40 milligrams and 80 milligrams. What's available in the country is 40 milligrams. 40 milligrams single dose for those patients with body weight of less than 80 kilograms. But if you are on the heavy side, or the patient is on the heavy side and weighs more than 80 kilograms, then the recommended dose is 80 milligram capsule. So since 40 milligrams are available in the country, you need to give 2 capsules single dose. And these are the recommended dosages. Just to compare the dosages between Baloxavir and oseltamivir. Baloxavir, again, it's a single dose regimen, depending on the weight of the patient, whether you give 40 milligram single dose or 80 milligram single dose. But for oseltamivir, for treatment, you give it 75 milligrams twice daily for at least 5 days. For rimantadine, if it's available, you give also twice daily for 7 days. So there is that advantage of giving single dose. Now, is it effective? Well, we'll see in the next coming slide whether single dose of Baloxavir is enough to control influenza, or maybe the 5-day regimen would still be more effective, because giving more antibiotics or antivirals might be more effective compared to just giving it as a single dose. That leads me to CAPSTONE-1. There will be 2 clinical trials that I'll be presenting. The results of these 2 trials will show the efficacy and safety of Baloxavir compared to the more commonly used oseltamivir. So for CAPSTONE-1, this studies the treatment of influenza in otherwise healthy adults and adolescents, meaning no other comorbidities, not the high-risk groups. And this involves patients aged 12 to 64 years of age with fever and at least 1 systemic symptom. So that's at least fever. Systemic symptom would be headache, chills, and fatigue. Respiratory symptom would be your cough, nasal congestion, and sore throat. And the onset of symptoms should be within 48 hours. And they were separated into 2 groups: the adolescents and the adults. The adults receive Baloxavir, oseltamivir, and the placebo. The young adolescents received Baloxavir and placebo. The study endpoints are the following. So the study endpoints, the primary efficacy endpoint would be time to alleviation of symptoms, that the TTAS. The secondary endpoints are the following: the TCVS, or the time to cessation of viral shedding, also the change from baseline in the viral titer, and those proportion of patients positive for the influenza viral titer and the proportion of patients positive by RT-PCR, and the baseline adjusted area under the curve for viral titer and amount of viral RNA. Also, clinically, these are the secondary efficacy endpoints: time to the resolution of fever, return to pre-influenza health status, time to elevation of the 4 systemic symptoms and the 3 respiratory symptoms, also the return to normal body temperature, and the time to elevations of individual symptoms, including the incidence of influenza-related complications. And another study endpoint would be your safety endpoints. And this includes the frequency and severity of adverse events. This table just shows that the patients enrolled in each arm did not differ significantly. They have the same demographic and baseline characteristics. And it shows the primary endpoint showed that the efficacy primary endpoint showed that Baloxavir has significantly reduced the time to alleviation of symptoms by more than 24 hours versus the placebo. So there is significant difference between those patients who receive Baloxavir compared to the placebo. And between Baloxavir and oseltamivir, there's no significant difference in terms of time to alleviation of symptoms. Remember, Baloxavir was just given for a single dose, while oseltamivir was given for 5 days, twice daily. Now, in terms of efficacy, the reduction of the viral titer versus the placebo and oseltamivir, again, Baloxavir significantly reduced the viral titers earlier and more effectively than placebo and oseltamivir. So the time to cessation of viral shedding, the TCVS, is faster or earlier among those who receive Baloxavir in 24 hours compared to oseltamivir and the placebo. 72 hours among those who receive oseltamivir and 96 hours among those who receive just the placebo. So these are significant results. In terms of the resolution of fever, again, Baloxavir significantly reduced the symptom compared to those who just received the placebo. And for those for the adverse events, Baloxavir adverse events, whether it's GI or neurologic adverse events, it does not show any significant difference in terms of the AEs observed among those who receive oseltamivir. So pare-pareho lang actually sila. Even the placebo, no significant difference. So what's the summary for CAPSTONE-1? Number 1, a single dose of Baloxavir is superior to placebo and comparable with oseltamivir in alleviating influenza symptoms. Number 2, a single dose of Baloxavir is superior to both placebo and oseltamivir in reducing your viral titers and time to cessation of viral shedding. And Baloxavir is well tolerated and associated with numerically fewer adverse events than oseltamivir. And the efficacy and safety profile of Baloxavir is consistent across otherwise healthy adult and adolescent population. Now let's go to CAPSTONE-2, because this now involves treatment of influenza in adults and adolescents at high risk of influenza-related complications. Patients who are considered high risk, like what I said in the previous slide, are those with other comorbidities, those who are more than 65 years old, American Indians and Alaskan Natives. Kumusta naman? Sana may makita tayong Alaskan Natives and American Indians sa Manila. But kung meron man, they are at high risk. Those with blood disorders, metabolic disorders, those who are morbidly obese, BMI more than 40, very common also among Filipinos, and the pregnant women, even those who just just delivered their pregnancy. This study involved patients more than 12 years of age, again with the same inclusion criteria in terms of the signs and symptoms, but this involves high-risk patients, not the otherwise healthy patients. And they were divided into three arms: Baloxavir arm, oseltamivir, oseltamivir arm, and the placebo arm. And these are the primary objectives and secondary objectives of the study. So the difference between CAPSTONE-1 and CAPSTONE-2, in CAPSTONE-1, the primary endpoint was time to alleviation of symptoms. While in CAPSTONE-2, it's time to improvement of influenza symptoms. And when we say improvement, it would mean improvement of the 7 influenza symptoms: cough, sore throat, headache, nasal congestion, fever and chills, muscle pains, and fatigue from the baseline. Or if they have pre-existing symptoms that were judged by the patient to be worse at baseline, it must improve for at least 21.5 hours. Some high-risk individuals kasi would have underlying comorbidities that shares the same symptoms as with those of influenza. And so there should be at least improvement of these symptoms if they have pre-existing symptoms prior to the onset of influenza. Or there's maintenance of the pre-existing symptoms that was not worsened by the onset of influenza. So these are the two the results of the ITTI, or intention to treat those infected with influenza population. And this is from those who receive Baloxavir and the placebo. And the baseline characteristics between those who receive Baloxavir, placebo, and oseltamivir are all the same, no significant difference. And this just also show that those who were given the treatment, that in terms of the time of onset of symptoms, did not differ significantly, and it's comparable across all treatment groups. Most of the time, the treatment was given more than 12 to 24 hours or 24 to 36 hours from the onset of symptoms. And majority of patients were infected with influenza A, H3, and influenza B, which are the common influenza strains infecting humans during the seasonal influenza. And this also shows the incidence of high-risk factors, and it's comparable across all treatment groups. Baloxavir, meaning those who receive Baloxavir did not have high severity complications or comorbids compared to the other treatment groups, so they're all the same. So that makes also the results very good or valid. So what are the results? In terms of the time to improve to the improvement of influenza symptoms, Baloxavir actually was noted to be superior versus the placebo in terms of improving the time to improve influenza symptoms. Now, compared to oseltamivir and placebo, Baloxavir is also superior in improving influenza symptoms if the influenza B is involved in the infection. For influenza AH3, also Baloxavir is superior compared to placebo in improving your influenza-associated symptoms. And the time to alleviation of influenza symptoms is also, Baloxavir is also superior to the placebo. Now, the time to resolution of fever, again, Baloxavir is superior to the placebo. Now, Baloxavir is also associated with lower incidence of all influenza-related complications, and that includes deaths, hospitalization, sinusitis, otitis media, bronchitis, and pneumonia. But significant differences were noted in sinusitis and bronchitis. And Baloxavir is also associated with significantly less fewer, significantly less influenza-related complications than your placebo. And for the reduction of viral titers, Baloxavir significantly reduces viral titers versus your placebo and oseltamivir in a 24 to 48-hour post dosage. Also, Baloxavir significantly reduced your viral titers involving influenza A, H3, and B viruses compared to the placebo and oseltamivir. And in terms of the time to stop or time to cessation of viral shedding, Baloxavir significantly shortened the time to cessation of viral shedding to 48 hours compared to your oseltamivir and placebo, which is 96 hours. Also, Baloxavir is associated with numerically fewer adverse events than your placebo and oseltamivir. Overall incidence of adverse events, however, was low for all treatment arms. In summary, Baloxavir is a safe and effective treatment for high-risk influenza patients, and that's the message we get from CAPSTONE-2. CAPSTONE-2 is the first randomized phase 3 trial to demonstrate a significant and clinically meaningful benefit in high-risk influenza patients for Baloxavir versus the placebo. It also demonstrated a significant benefit over placebo and oseltamivir in high-risk patients with influenza B infection, a subgroup where most antiviral treatments have shown only limited efficacy or inconclusive data. Now, Baloxavir was associated with significantly fewer influenza-related complications than with placebo and numerically fewer than with oseltamivir. And the key results in the clinical trials, actually this is just, if for all the past slides that I've discussed with you, ito lang actually yung pinaka-importanting slide because this summarizes the clinical trial results of both CAPSTONE-1 and CAPSTONE-2, showing that for alleviation of symptoms, Baloxavir is significantly more effective than the placebo. And for reduction of viral concentration, Baloxavir is also more effective than your Tamiflu or oseltamivir and the placebo. In terms of this adverse event, there's no significant difference between those patients who receive Baloxavir, oseltamivir, and placebo in terms of adverse events associated with the treatment. So the key takeaways from this talk: number one, there are different strategies to reduce influenza transmission, and these are integral in mitigating potential public health hazards. Diagnostic flu testing facilitates timely screening and detection among those with uncomplicated influenza and high-risk individuals, while also contributing to antibiotic stewardship. So if it's available, if diagnostic testing is available, then use it. And if the only problem there is actually the cost. Early intervention with antiviral can reduce the risk of complications and mortality. And there is a new one-dose antiviral treatment for influenza, and it is available in the Philippines, and it's brought to us by Roche Philippines, and that's Baloxavir marboxil with the brand name Xofluza. And these are the references cited in this talk. Again, good afternoon, and thank you for listening. Back to you, Susie.
Thank you so much, Doc Mark, for your presentation. Very complete. And of course, we would like to say hello and good afternoon also to our attendees this afternoon. I think we have 47 of them, Doc, but only one question so far. So we would like to encourage our other members of the audience. If you have any questions about the talk that you've just heard from Dr. Mark, please do send that in the Q&A portion of our Zoom meeting or our broadcast this afternoon. Now, for the first question, or the question that we have here, the question here for you, Doc, is any local studies comparing oseltamivir and Baloxavir?
The CAPSTONE-1 and CAPSTONE-2 are clinical trials conducted in the US and Japan. I'm not aware if there is an ongoing clinical trial for Baloxavir and oseltamivir using patients coming from the Philippines. I think the best person to answer that would be anyone from Roche.
Right. At dahil sinabi mo yan, Doc, sumagot naman agad si Edgar. At
Yeah,
ang sabi
there's
niya
none.
ay none in the
Not in the
Philippines.
Philippines. Yeah.
None in the Philippines. Okay, okay. So, Doc, may kinalaman yung ethnicity ba sa ano, when it comes to researches like that? Is that what you're saying? Yung kaya none in the Philippines?
It depends on if the one conducting the study would like to include patients from a certain country, then this investigator should coordinate with those study sites. So it actually depends on the extent of the study, the budget of the study. If you, syempre, if you will include other ethnicities, other countries, not just Americans, but also other ethnicities, then that makes the study even more powerful, even the results even more valid.
I see, I see. Oh, we've got a couple more questions. We have a question from Judith Reyes. Ito na ang magandang tanong. How much does... Dahil babae siya, syempre yan din yung tatanong niya, di ba? Dahil yan din yung una kong tinanong sa inyo noon. How much does Baloxavir cost? She's asking about 40 milligrams and 80 milligrams.
What's available in the country is 40 milligrams po. So, according sa aking bubwit, it costs around 2,500 to 4,000 per pill. So, if you are a person weighing less than 80 milligrams, then the recommended dose is just one pill of 40 milligrams. More than 80 milligrams.
80 kilograms. 80 kilograms.
80 kilograms. More than 80 kilograms, you need to receive 80 milligrams of the Baloxavir. So, do the math.
Right, right. So 80, kasi nag-math din nga ako, 2.2 pounds yata. Tama ba? Pag kilograms? So mga 100, yun ano? So mga 165, 170 pounds or below, pwedeng one dose lang. Pero kung over that, so kailangan mag-take ng 2 pills. Sabay na yun iinumin, no, Doc?
Yep, sabay. So one dose lang. So 80 kilograms times 2.2, that's your pounds.
And then you need to take 2 if you're more than that. And also, you mentioned also earlier, Doc, na isa din sa mga risks is obesity. So if you're a lot more than that, also, di ba, yung 80 kilograms na yan, I mean, depends of course on your height, etc. No? Pero that's also a risk factor, no? Do sa mga...
The problem here, influenza kasi is something, from my experience in clinical practice, it's one of the viruses that is really commonly neglected.
Yes.
Before. You get this parang trangkaso or symptoms. Ano lang yan, simpleng sipon, simpleng ubo, or flu. Then you have patients, I've seen patients who really became critically ill. Very seldom that you consider, baka there's really just influenza.
Yes.
Until, the game changer is COVID-19.
Yeah.
So that we never realize that a certain virus or viruses can actually cause a lot of havoc in humans, like COVID-19. And that also makes influenza more relevant now, because we cannot just say that this is just a virus. Because viruses can really cause a lot of problems clinically, especially those who are vulnerable. And those when I say vulnerable, these are children, senior citizen, and those with other illnesses.
Pre-existing conditions. Actually, when we talk about the common flu, even if I think, 7 days, Doc? No, parang 7 to 10 days, parang ganyan yung...
5 to 7 days.
5 to 7 days. Pero even after that, parang the body is still recovering eh. So pwede ka nang pumasok sa work or magtrabaho or something, but you're still not 100%?
Yes. There's that post-viral syndrome wherein you still feel sick, although you're no longer contagious, you're no longer infectious, but the after effect of the virus, especially if you had a very high viral load, you can still experience those symptoms days after the time that you were really sick.
Right. Doc, meron tayo additional information dito galing sa ating bubwit. Talagang yun yung tinawag natin kay Edgar. Baloxavir has also been approved by the US FDA for prophylaxis recently. That's
Okay.
very recently, November 24 kasi siya this year. Pero locally, dito sa Philippines, it has not yet been approved as a
So,
prophylaxis.
for prophylaxis, for influenza.
For influenza, yes. Pero ano, next year, I hear, Doc, na starting January, magiging available na rin itong ating Xofluza sa ating mga major drugstores nationwide. So that's good news, lalo na ang lamig, Doc, ha? I mean, if you can feel the weather, it's really changing, di ba? So all the more na maraming chances na we catch influenza, and of course, those people nga of pre-existing conditions, mas malalagay sila, posibleng malagay sila sa alanganin. So it's good that the doctors have an option to give this to their patients.
Correct. Christmas season is influenza season. So you should have gotten your flu shots
That's
a few months
right.
ago, a few months before
Yes.
the influenza season.
Yes. Yes. Pero Doc, 'di ba? I mean, if you get the flu shot and then the variety, hindi ko alam kung tama yung sinasabi ko, of flu that is predicted there in the flu shot for this year, posible ka pa rin magka-flu kung hindi kasama yung dun sa na-project for this year. Is that right?
The flu shots only contains 3 to 4 kinds of influenza. 2 influenza A and 2 influenza B. And these
Mhm.
are the common influenza strains based
Mhm.
on studies
Right.
in the previous year. So
Mhm.
you get protection from flu shots against the most common influenza viruses.
Mhm.
But you
Mhm.
may still have, the usual trancaso common colds, but this may be because of the less common and less potent influenza strains.
Okay. So at least you know na parang if you do get the flu shot, for the most part, that should protect you from the common
Correct.
versions of the flu.
Correct.
Yan. Doc, maraming salamat. Baka meron kang last words of advice, I guess, for our attendees. We have 50 attendees, so we'd like to thank you guys for choosing pala to attend our talk this afternoon.
Again, thank you for logging in, and thank you, Susie, for moderating this talk. Suki na.
Always a pleasure, Doc. Alam mo
Hopefully, we'll
yan.
see you again next time.
Yes,
Thank
please.
you, thank you for logging in to this Roche symposium, and let's wait until Baloxavir will be widely available in the country. It shows its efficacy and safety, and hopefully it will be very helpful in the control of influenza in the country. And let's also hope and pray that COVID-19 will be gone soon. Thank you, and still safe. Stay safe, and I hope to see you again. See you the next plenary session. The PISMI convention is still not over until 9 p.m. tonight.
Right, that's right. Marami pa kayo mga activities ngayon, Doc Mark. So pahinga-pahinga ka lang ng sandali until your next plenary. Maraming salamat for joining us, and of course, for the very informative presentation. Of course, to protect our loved ones from the serious effects of influenza. Syempre, dahil nasabi na nga po natin, meron tayong pagkakataon ngayon, meron tayong option with Baloxavir or with Xofluza. And the great news is that it will be available starting January next year sa ating po mga big drugstores. That would be Mercury Drug and Watson's. All right, we've got 61 attendees. We want to say thank you once again for choosing to attend our talk this afternoon, sponsored by Roche Philippines, introducing Xofluza nga, para meron po nga option po kayo na pwedeng maging consideration, lalo na kapag kayo ay may mga pasyente who have pre-existing conditions, who are prone to having complications if ever they do acquire influenza. So thank you once again. We'd like to call at this point Dr. Catherine Amalia Colaiko for our closing remarks. She is a fellow of the Philippine Society for Microbiology and Infectious Diseases. Dr. Colaiko?
Good afternoon. Thank you, Dr. Mark Pasayan, for that very timely lecture on reducing the burden of influenza amongst adults or adult influenza with the new antiviral, particularly Baloxavir. It was very interesting to listen to. And of course, we'd like to thank Ms. Susie Andrada, our moderator, for facilitating this afternoon's discussion. Um, So, on behalf of the PSMID and its Board of Councils, I'd like to thank Roche for partnering with us in mounting our 42nd annual convention. Now, more than ever, the PSMID feels that proper communication of scientific lessons is very essential. And your partnership in this endeavor has really helped to contribute to this and to make it happen. So again, thank you very much to Roche. We shall be sending the certificates of appreciation for both Dr. Mark and Roche through email. And to all our attendees, thank you for attending. We look forward to still seeing you. We have two more sessions to go before our big gala night. So our next session will start at 5 o'clock. Please don't forget to log out of this Zoom room and go back to the main convention website so you can log into the next plenary. Thank you very much, Roche, Dr. Mark, Ma'am Susie, and to everyone who attended. Thank you.
Thank you so much, Dr. Catherine Amalia Colaiko. Thank you for giving those closing remarks. And of course, that's it. Thank you so much, dear doctors, for joining our industry-sponsored lecture from Roche. We hope that the information that you have gained from Dr. Pasayan's talk will serve you and your patients well. This has been Susie Entrata Abrera. Thanks again, and enjoy the rest of your day. Stay safe and healthy. God bless you.
Thank you.